As you're coming in, if you want to grab, there are handouts up here at the front table. Feel free to grab one yourself. Otherwise, we might try to disperse them a little bit as we move on. And if you're flipping through the slides, you're probably going to see that they're pretty jam-packed and look like a textbook. So I'm not going to read them to you, but this stuff is good information for you to keep and read at your leisure. And if you've got any questions, you'll see how to contact me later if you want to.
Muted.
No, it's fine. I just wanted, it was already on.
No. Give me that. You good, man.
Cool.
Ask one of our associates how to get your own sweet sleeper back.
Real interesting.
We'd like you to be part of our Starwood Preferred Guest community if you're not already a member. You can earn star points for all your stays at participating Sheraton hotels and redeem them for great rewards and free nights at over 800 hotels and resorts that are part of the program around the world. Please hold on, and we'll be right with you.
You don't just stay at Sheraton, you belong. So if there's anything we
Is there anyone else who is in here that's an HDSA staff member that I could steal real quick, besides Manelli? Any sucker who wants to volunteer for something real fast? I should be gracious volunteer. As people are coming in, do you mind just taking some of the handouts and seeing if people want them? If you came in and you don't have a handout, just raise your hand and we'll try to pass some of this down to you, right? Thank you so much. I appreciate it. All right, and we're gonna get going here too. So my name is, well, this is what we're talking about. We're going to be discussing psychiatric issues in HD. We're going to focus a little bit more on early stages in HD. However, the things that we discuss today, you'll see translate into the middle and late stages as well. All right. Oh, that part's working. There we go. So my name is Dr. Eric Johnson. I'm a clinical psychologist, and I work with the Center of Excellence out at UCLA. But I want to welcome you to Minnesota as a born and raised Minnesotan. So probably by the end of this presentation, you might hear my O's getting a little bit longer. Or I'll use the you betcha you were all introduced to this morning. This is our standardized disclaimer. What I want to point out is please understand that the things we talk about today are general. These are not diagnostic-specific things for individuals in this room. And the interventions and the medications and things that are discussed today, please take that information to a treating physician, whether it's a neurologist, your internist, your psychiatrist. Any of these interventions should be discussed with a doctor that you are working with. These are just general recommendations. As far as financial disclosures, I have none. If you want to throw money my way, I'm always willing. The main point of the discussion here this afternoon is to discuss some of the psychiatric presentations that can come up in early stages of HD. Now, what we're going to do is discuss ways of identifying those things. We're going to talk about the impact that it might have on a person's experience, trying to aim more at the idea of someone who's in the early stages of HD, but things that you can kind of translate yourself into your own experience as well. We'll review some medications that can be used for these specific disorders. And lastly, I'm going to talk about some things that you can do that aren't medicinal. So these are active interventions, things that a psychologist like myself might work with you on, any counselor you might meet with, etc. Thank you so much for handing those pamphlets out. I appreciate that. Now, just want to clarify something too. If who was here for Dr. Wheelock's speech? You're going to hear a lot of things that sound really similar. She was talking about difficult behaviors. I'm talking about psychiatric issues. Oftentimes we'll use those terms interchangeably. However, I don't feel it's a bad thing to repeat some of it. So if you're looking up at the screen right now, you're going to see, we just talked about depression, anxiety, irritability and anger, and apathy. We're going to talk about them again, but we're going to talk about them in a slightly different way, and again looking at them from a more early stage perspective. I am not going to touch a lot on psychotic disorders, which are things like hallucinations. Yeah, I hear, God's talking to me right now. Can't you hear him or her? Or visual hallucinations. You all see Fred, right? We're not going to talk about that today because they do occur, but they're not all that common. If this is how you're going to respond to my attempts at humor, I may just have to cash it in right now. They're less common. They do occur. If it's something that you've experienced and you want to talk about, I'm more than happy to talk about it a little bit later. But for the sake of our discussion today, I'm going to talk about the big four that I got up there because those are things we see more in an early stage HD patient. Why do I like to talk about psychiatric disorders? Because they are treatable. And I want to emphasize the term treatable does not mean curable, but we can treat psychiatric disorders, whether it is through use of medication or whether it's through behavioral intervention or a combination of the two, right? We want you to know that these things are things we can work with. However, just another disclaimer, psychotic symptoms are harder to treat. It's just the way it goes, sorry. I wanted to point this out. If any of you got to see Dr. Paulson speak today, she spoke about some of the cognitive issues that can come up in early stage HD. It does complicate the way people can deal with the psychiatric disorder. Why? Because with the cognitive impact, things like slowing down a thought process, being able to multitask and differentiate things, that is going to make it harder to deal with things like emotional lability, which basically just means your mood goes up and down real fast or varies a lot, right? If something happens that stresses me out, I might not be able to address it as easily as the quote-unquote normal person if I have HD because of a cognitive change that is occurring in the brain as well. So while we do talk about interventions, and I think Dr. Wheelock had said sometimes the interventions that psychologists use don't work so great for the individual with HD, I'm going to say try it anyways. And particularly when we're talking about people who are in the earlier stages of the disease too. If you can practice these things, can you get good enough at them that they're going to have a little bit of a lasting effect? I also think that by taking an active approach to things like a counseling intervention or a behavioral intervention has an added bonus that it gives you a sense of, I'm doing something about this, right? Taking a pill, you're doing something about it, although a lot of people come into my office and say, well, I take the Wellbutrin every day, but big deal, I'm not doing that. Yes, you are. You are the one who's choosing to take that pill. However, we're going to talk about things that are a little bit more active than that. How do we treat psychiatric presentations in HD? It's the same way we treat any sort of symptom of HD. We're treating the symptom. We're not treating the cause. We can't go in and do anything about this gene that is causing these changes to occur in the brain, but we can treat the symptoms that are presented. And how do we do that? A lot of it is based on medicine or pharmacological. I'm not going to say that a whole lot, but it's the pills that we can have people prescribed, right? So there's medications that are very good at treating the symptoms of HD. good enough at treating the symptoms of HD sometimes. But we are always looking at seeing if we can take those problematic symptoms and reduce them, right? A goal should not be to make the symptoms go away. I can't emphasize that enough. If you go in thinking, oh, I'm going to go and, I've been depressed, so I'm going to take this pill and the depression's going to go away. You want it to get better, right? That's very different than saying it's gone. Because if you go in and say the only way that I'm going to measure this as being successful is if I'm not depressed anymore, you might be setting yourself up for failure. But if you go in and say, if I'm not as depressed tomorrow as I am today, I'm doing better, right? So we want to see symptoms reduced, not erased. Whenever it comes to treating psychiatric symptoms. Medications, they're great, they're effective, but they only address the changes in the brain that are leading to those psychiatric presentations. I'm going to talk a little bit about this in a moment. We do know that behavioral interventions are also indicated for all of these things, like anxiety, depression, obsessive-compulsive disorder, anger management. There are active techniques that can also be just as useful. So this seems like it makes common sense. What's going to work best? Use the medications, use the interventions. Do them together. Don't just go in and say, oh, I see my doctor once every 6 months, and they check on my Zoloft level. Well, what are you doing in between besides just taking the pill? Is there something that you could be doing actively at home by yourself, with your spouse, with your parent, whoever? Are there things that you can do in tandem with taking medication? I say go for it. The more that you can do, the more that you can benefit. All right, I emphasized this already in the little disclaimer at the start, but this is my own personal beating a dead horse. The things that we're talking about today are general. Psychiatric presentations look different from individual to individual. There's a lot of similarities, but there is a lot of difference. Just like HD looks different from person to person. We're going to talk about psychiatric disorders the same way and think about it that way. Treatment and care plans, they're going to be as unique as the individual, and you should really be working with someone on this, okay? First, if you are going to be doing a medication, please consult with a doctor. Don't go into the medicine cabinet and say, well, Dad takes his Zoloft. What if I just start taking it? Not only are you taking it away from Dad, but you might not be giving yourself the right dosage or even the right medication for what you're dealing with. If you think a medication is an appropriate intervention, talk to a doctor. Talk to a medical doctor who can prescribe. Your neurologist, a psychiatrist, or even your general practitioner, okay? If possible, now I'm being a little more lenient on this one. I wish everyone had access to a psychologist, a social worker, a marriage and family therapist, a counselor of any sort. If you want to do any sort of active intervention, I wish for you to have access to a person like that. It's not always realistic. Someone might live, I live in LA now, and if you drive like an hour out of LA and all of a sudden you're in the desert. What if there's not a counselor out there in the desert? Or you live in a very remote part of Minnesota, up around, oh man, what's it called? What are the big lakes where we'd like to go with, the canoes and Ely? That's not what I was thinking. It was actually Boundary Waters. Thank you. Man, I've been away a long time. That's sad. Okay, back to what I'm talking about. You might not. So the whole point of that was you might not have access. I wish that for everybody. You might not have it. Try to find it. Right? If you are thinking of doing an active intervention, please try to find someone you can work with. Because it's oftentimes good to have someone outside of your family who's not dealing with all the other stuff that's going on in your situation, where you can go into their office maybe once a week and say, okay, here's what I'm feeling. What can we do about it? Right? It's a great opportunity. And just because you're seeing a psychologist does not mean you're crazy. I can't tell you how often I hear that one. Why was I referred to you? Is the doctor telling me it's all in my head? Boy, if that's the the stigma that comes with a visit to my office, that's kind of sad. There's a lot of things we can do that don't say you're a crazy person. If you're talking to Giant Blue Fred here in the corner, well, maybe you're a little crazy, but we can work with that too. I want to talk about the difference between reactionary, and neurophysiological causes for mood disorders or psychiatric issues. Reactionary is basically in response to something. You just went and got a gene test, and you've been waiting for a month for the results, which is stressful. You know that tomorrow is the day that you're going in, and you don't sleep the night before. You go into the test, and the genetic counselor says, you have tested positive for the expansion for HD. What might you feel? Sad? Mad? Anxious? These are reactions. They are normal and appropriate, okay? These are things that people have. Now, I use just a really dramatic example for this room, but you're watching, oh man, I'll own up to my own sappiness here of, God, what's a good movie where a dog dies? You'll get me every time. I'm not even going to talk about it right now because I'll probably start crying, and that's not good. But you react to things. Yeah, okay, I know, I'm sorry. The deer died. Thank you. Right, much better. Sorry. Reactionary. This was a good reaction that we just illustrated. Thank you for taking part in a modeling exercise. Reactionary emotional experience is normal and understandable, and we can work with it. It's not always, oh, I went home, I cried for a while, and then got over it. Sometimes it goes on for a while, right? I just got a positive gene test, and I've been depressed for about 4 or 5 months now. This is normal. But how do we talk about when it transitions into this neurophysiological, which is oftentimes just due to the changes in the brain? A lot of things that we take into account are timing. Have you had a depressed mood for 4 weeks? Okay, might still be a reactionary thing. Have you been depressed for 9 months? Okay, we're talking about something a little bit more here. The thing is, we're going to treat the symptoms the same way, right? Very often when a person comes in for a gene test result, we're going to want to see them back again in like a month's time, okay? Because we want to know how you've been doing. We'll see you before then too, by the way. But we want to call a person back in because we want to know what's been happening. Have you been skipping work every day for the last 4 weeks? Have you been sleeping until 1 o'clock? Have you been crying every day? We want to know these things because we can help. There are things that are available, whether it's a medication or whether it is an intervention. So let's talk about what some of the common psychiatric presentations are. And I'm just looking at my clock because I want to do this on time. First and foremost, particularly in early stage, we do see evidence of depression, people suffering from depression. And depression is different than just, I feel sad, right? It's bigger than that. So there's things that we're going to look for. Now what I've provided, and this is in your handout, so I'm not going to read it down for you, but these are the standard, what we get from the Diagnostic and Statistical Manual for, it's what shrinks use to diagnose you, right? We call it DSM-4 TR. Diagnostic and Statistical Manual, I think that's about it. Okay, I was right. These are the symptoms that we use to diagnose depression. Depressed mood most of the day, but we want to see it repeatedly. Oh, I was depressed on Monday. Tuesday through Friday was great, right? No, if depression is going to be something that's more consistent than that. It's going to be longer standing and longer lasting. Decreased interest in things. Now, this is where it gets complicated when we're talking about HD because we'll talk about apathy again in a bit. Apathy isn't a diagnostic term, but it's one that we hear a lot in this population, okay? Changes in appetite or weight. Again, we're talking about HD, so there's going to be some lines that get blurred here. But if we see significant weight loss or significant weight gain in a fairly short period of time, which is a matter of months again, that's something that can be seen as a symptom here. Sleeping all day or rarely sleeping. As you're seeing, it's a lot of extremes, right? It's either too much or too little, right? A lot of people think, well, the depressed person, what they're doing, they're crying all the time, they're sleeping all the time. No, they might not be sleeping at all, right? Depression. I think it's very stereotypical to think about the depressed person eating, right? I feel so bad, I'm going to eat this whole bag of Doritos, all 4 of those hot dogs, that gallon of ice cream in there, and then we'll go to dinner. There is one thing that I think is really key, and think about this. Excessive feelings of unworthiness or guilt. When we're talking about early stage HD, let's imagine that you are a young parent. You've got a 2-year-old, and you just found out that your mom has Huntington's disease. It's not that she was a drunk. Mom actually has Huntington's disease. Well, what does that mean? Now I'm at risk. And my child is now at risk, right? I can't tell you how often I have people come in and there's just this guilt, like, what have I done? And I can't tell you how hard I will work with a person on that to say, we can normalize this. You can work with that. But it's a very normal thing to occur, and something that we see quite frequently in HD. What I'm showing right now is anecdotal information too. This is what I learned from being in clinic. It's not necessarily something you're going to go see statistics for, but this is from someone who works in an HD clinic. We hear a lot of that, okay? And thoughts about death or suicide. I'm going to touch on that in just a little bit. There's an example. This isn't an actual patient of mine. This is kind of a combination of people that I know. You can read through it, and what I would like you to do on your own time, it's almost like I'm assigning homework to people that I'm not going to see again, but take a look at this example. See if you identify with anything in this example, and then go back and look at those diagnostic criteria. See if anything stands out. I'm not going to give you a whole lot of time to do this, but just take a look at it now and note that there are things that might sound really familiar. You know, here's a guy who's working. He had a big old screw up. He probably feels really bad about that. But now he's starting to think negatively about things or thinking he's not good enough, right? Yeah, I made a big mistake. Now the boss must know that I'm not able to do things like I used to. As a psychologist, I will argue that all the time. You made one mistake. Does that mean that everything else is seen as a mistake? Not necessarily. You could be making consistent mistakes, but if you think now that everything is wrong, how's that going to make you feel? Depression can get exacerbated or made worse. Stereotypical again, you know, he's not playing with the kids like he used to. He doesn't have energy. All of these things kind of play into our diagnostic criteria. So what can we do about it? There are a lot of things that can be used to treat depression, and from a medical standpoint, it's nice when depression comes into your room because there's a big arsenal of things to use. Now, the primary treatment that is used for depression are these SSRIs, or the selective serotonin reuptake inhibitors. I'm not giving you a biology lesson right now, but just understand that that classifies these meds because they all act in the same way in changing the way neurochemicals are transmitted in the brain to make a person less depressed. Okay? You might know these because a lot of them you see on TV commercials, right? Depression hurts. This is that, you know, little wind-up doll lady. Some of these, not so much because they're around and everyone just knows what they are, right? The SSRIs are a nice class of meds, and it's those big five at the top that we generally will apply in a lot of situations, okay? Prozac, classic, right? Prozac Nation, when was that written? I should know that if I was going to mention it, but I don't. Zoloft is a really common one, and you're going to see why I say it's a common one, because when we get to talking about the different disorders, I'm going to say, please see the previous list. We use the SSRIs a lot. The more interesting ones. Yes, ma'am. Okay, let me try to, I'm going to rephrase that just so I repeat it for the folks that are online, by the way. Hi, online folks. You understand that depression is a clinical malady, and you want to know how we know if it's being treated appropriately? I'm sorry if I totally jumbled it. Yes, there is a lot of research backup for all of these things. Is it research backup specific to the HD population? There are some studies out there, but we're also going to take from the larger pool of research that shows these things are effective. Now, they come from the big drug companies too, so you know there's a lot of money behind the work that has been done. That's not a bad thing, okay? Anecdotally, and from a clinical perspective too, if we put someone on a medication like this, we are going to want to follow up, right? We're not going to say, okay, start Zoloft, come back in a year for your next appointment. We're going to say, start so lost, I want to see you back in 4 weeks. Have you had any side effects? Are you feeling any different? We'll say you probably shouldn't feel any different because generally these things take 4 to 6 weeks to really hit a therapeutic dose in your system. And even after 6 weeks, you might be saying, well, I'm not feeling a whole lot of anything, and we'll say that's because it needs to go up. These are things you want to work with a medical doctor on because they're going to help monitor that, right? We're going to ask a lot of questions. We're going to do a lot of assessments to see if they're working. Does that answer your question at all, or did I just totally go dance off on another topic? Okay, thank you. These other ones, the SNRIs, they just change different neurochemicals. One big one that you've probably heard about and hear more about is Effexor. Why? Because when we get to talking about things like apathy, Effexor can sometimes have a little bit of an energizing effect. Cymbalta is the one, depression hurts. It's often used for people who are in chronic pain, which we talked, I think there was another discussion either today or tomorrow about pain in HD. There are what we call the atypicals. A lot of people probably know this. Has anyone tried to quit smoking and been on Zyban or Wellbutrin? Did it work? Great. Who said that? Congratulations. Buspar is an interesting one, and one that is sometimes looked at in HD. Again, this is anecdotal, but Buspar has a side effect of causing people to gain weight. Now, in the quote-unquote normal population, people might not like that. But if we're talking about people who have a little bit later stage HD who are having troubles keeping weight on, sometimes a medication that has that added bonus can be a good thing. I added Abilify to this list just because it's one we're seeing more and more of now. It's a different agent, but what it helps do is boost the effectiveness of an antidepressant medication. I'm not going to go into all the neurochemistry of this stuff. If you want to know, take this list to your doctor and say, hey, these are things that we heard about. You can find out a lot more information about it. And again, nothing should be done without a medical doctor approving it and prescribing it. Now let me talk about the things that you can do. Interventionally or active interventions, what we call behavioral interventions. First and foremost, talk about it. If you've been sitting at home depressed for the last 16 months, please tell your doctor, please tell a spouse, please tell someone at church, please tell a best friend, talk about it. Start engaging with this. There is something you can do about it. A lot of times people who are depressed have this negative mindset. Well, why even bother? You know, it's never going to get any better. Why should I even try? Get the ball rolling. There is a lot that can be done, right? I work a lot with pre-symptomatic individuals in my own practice, and it's understandable. You have someone who's 24, who's just tested, who knows that they have this gene, and they're saying, well, you know, why even bother? Because when I'm 35, this is going to happen. Okay. I like that you've got a crystal ball that tells you exactly what's going to happen anyway. Let's go down and buy some lotto tickets because I would like to retire someday, and that sounds like an easy way out. Challenge those beliefs, right? When we're depressed, we think negatively. When we think negatively, we get more depressed. Talk to someone about it. You can work with these things. Talk to your doctors about medications. I'm going to keep emphasizing that. You got to talk to a medical doctor about medications, and work with a medical doctor if you are interested in medication. Medications aren't bad things. They are tools. They are tools that people use. Right? You are in control of that pill. You put it in your mouth. You're the one who talked to the doctor about it. It's your tool to use if you're feeling depressed. This is a shameless plug for anyone who's a part of a local chapter or a social worker or engages in a support group. Go to one. It's really, really good to know that you're not the only one dealing with something. Finding social support. And when we're talking about the HD community, this is a small population, meaning there's not that many people in the U.S. or even the world that have HD. But if you can get together, you can at least be with someone else who might get it a little bit. Even if you can't find a support group, maybe you can find a counselor who has a really good way of connecting with people. They might not know HD, but they might know how to work with you, and they can connect with you, and you might not feel so alone. Find a support group. Find someone to talk to about it. If you're depressed, we always encourage activities. Exercise. Be active. It is very normal for a depressed person to kind of check out. What's your exercise? I throw the covers up over my head. All right. Do that about 100 times, and now we're talking. Engage in hobbies. If you've got someone else in your life that can encourage these things, it's great. If you've got someone in your life who is demanding you do these things, that's not great. I don't know about you all, but if someone's saying, Eric, you got to do this, my heels are planted pretty firmly, especially if I'm depressed. Having support, having people who can gently encourage and remind. Now, that's asking a lot of that other person, and we're not in a caregiver group right now because I would address that a whole different way. But if you've got someone that you can turn to, that you can rely on, find a way to work together. Easier said than done when you're depressed, but you can try. Try to maintain routines and schedules. Dr. Wheelock said this. You're going to hear it all the time in HD. Get a routine, get a schedule, stick to it. I have a phone that has my calendar on it, and it beeps at me when I'm supposed to be doing things. Set things up like that that are going to remind you and encourage you to do things. It doesn't hurt to tap into technology or, again, to an outside source. And lastly, monitor for suicidal thoughts. If someone's depressed, we want to know if suicide is coming up at all because we want to address it if and when it does. Why? Well, okay. If someone's suicidal, let the doctor know. Just do that, please. If your wife comes home and she's like, man, I just, I don't even know if I care if I wake up tomorrow morning. Okay, you don't need to call the doctor right away. But you might want to say, this is maybe something we should talk to Dr. So-and-so about. Again, I'm a psychologist. I'm not a neurologist. I like to talk about suicide. And I probably turn a bunch of patients off because sometimes, well, it sounds like you're really, not doing so well. Do you ever think of taking your own life? And I can't tell you how often people are like, yes, but I can't tell anyone that because it freaks them out. Well, let's talk about it. It is important. It is something that we should discuss. We're in a room in an HD convention. If someone in here hasn't thought about this, I'd be surprised. And that's a big general statement, okay? It's a big general statement. I'm not saying you have to, but I will say I wouldn't be surprised. It's something that's very common, and it's okay to talk about, but talk to people that can work with it. Your neurologist, your psychiatrist, your psychologist or counselor. You can talk about it in families, but families oftentimes respond differently. I'm not saying not to talk to the family about it, but if it is present, if you are having thoughts about suicide, talk to someone about it. Because sometimes it just feels good to say, yeah, that was on my mind. I'm not going to do it, but man, I've been thinking about it a lot for the last couple of weeks. Okay, why aren't you doing it? Well, I love my wife. I really, kind of do enjoy going to work. I think about it, but I'm not going to do it. If someone comes in and says, Eric, I've got a bottle of pills in the car and, a bottle of whiskey right next to that and a shotgun right next to that, maybe we need to talk as we're walking to the hospital. But I'm glad you brought it up because it would have been so much easier for you not to say anything, so I do appreciate that. Talk to someone. Let the doctors know. I make jokes, but I don't mean to make light because it is something that I think is important, and I want people to be able to have that. Not every person is as good about hearing about it, which is why it's good to find a counselor. You could go into your doctor and say, hey, I'm thinking about suicide, and they freak out. It doesn't need to be that way. If it does happen, you're going to have my contact information at the end of the slide. Let me know, and I'll get in touch with that doctor. What about suicide in HD? Why do we talk about it? Because we do know that there is a higher than normal suicide rate in HD. We know that it's about 4 to 5 times higher than the normal national level. So it is important for us to talk about and to assess clinically. Why is it important for us? Because we do know that things like impulsivity, that difficulty managing emotions that's so common to find in HD, can impact the way a person handles suicidal thoughts. If you were in Dr. Jane Paulson's presentation, she talked about that gate, the caudate gate. Gate flies open because I think I should kill myself. In a quote-unquote normal person, the gate closes before the person does something. But the HD person whose gate is now stuck open and has impulsive tendencies, that's when we're concerned. So we want to look at things like that. When you're working with the doctors, they're paying attention to those things. So if you do say I'm suicidal and they also know that you tried to jump out of the car 3 times in the last week, it might be something that we look at a little bit more closely. Again, talk about it, talk about it, talk about it. Moving on. Anxiety disorders. I like to talk about anxiety in HD a little bit differently because there's a lot of specific anxiety disorders. I want to give you flavors of 3 of the bigger ones. Anxiety, or generalized anxiety, social anxiety, and obsessive-compulsive, now I'm clarifying this, type features. OCD, obsessive-compulsive disorder, is a thing in itself, but we don't always see the true OCD in HD. We oftentimes see a lot of pieces of it, so we can work with that. So I want to talk about it as a class of disorders. Why as a class? Because a lot of the treatments are going to be the same. So while there are different pieces of those things, we don't always see the true presentation. I didn't include panic. Why? I don't know. Panic is interesting, but we also can think of it as heightened states of anxiety. Panic is often very physically focused, like, oh my God, I'm having a heart attack, or I can't catch my breath. That does happen in anxiety too, so I'm including it in there. What are the symptoms of anxiety? Excessive worry, a lot of it, way more than is appropriate for the situation. Oh my God, I just dropped my phone, and well, you dropped your phone, pick it up, right? The anxious person isn't calming down. How is that in HD? When again, we're talking about that emotional regulation issue. We might see a lot longer presentation of anxiety. So just note that again, there are complications that make our traditional diagnoses a little bit difficult in HD. You have a hard time controlling the worry. That's important. And then a lot of times there's these physical symptoms, but again, restlessness in a person who has HD, difficulty concentrating in a person who has HD, muscle tension, irritability, sleep disturbances, all of those things you can look at and go, well, not only are those things that are diagnostic for anxiety, but those are some features of HD, period. So it can be difficult. You don't want to diagnose yourself. Talk to a doctor. Someone's going to be trained in HD, hopefully, and be able to work with you on those things. I really wanted to include social anxiety in this one. Why? If we're talking about a person in the early stages of HD, and when we say early stage, this is generally someone who doesn't have a lot of obvious motor signs yet. This might be someone who has a harder time processing information. Maybe they lose their temper more often than they used to. But they don't have obvious chorea yet. Maybe they've got slight facial tics, or maybe just a slight hand movement they can easily cover up. Anyone ever been in that boat and thought, oh my God, everyone's going to see what's going on. Everyone can see this is happening. Or let's talk about that, how old did I make my pre-symptomatic patient before? 24, who now knows that she's got the expanded gene. I dropped this on the way up the stairs today. It's got to be the HD. Oh my God, I forgot your name. It's got to be the HD. Never mind, I haven't seen you for 3 years, but it's just over-focusing on things. And it's over-focusing on things that are usually coming out in a social setting. Okay, so that's why it's social anxiety. It's being afraid of being in that situation. If I go to work, everyone's going to see that my hand moves. If I go to work, they're going to know that I don't know what's going on, right? Or I can't keep up with the way things have been. Lastly, the obsessive-compulsive type features, repetitive thoughts. If you've heard me talk, you've heard me talk about that. I want to go to McDonald's, guy. I want to go to McDonald's. I want to go to McDonald's now. I want to go to McDonald's. When are we going? You said we'd go to McDonald's today. When are we going to McDonald's? I want to go to McDonald's. Sounds silly, but it's been in the office. It is something that we see, and it's this repetition. And sometimes it's problematic, right? In true OCD, sometimes it's these really scary thoughts. But in HD and these obsessive type thoughts, it's not always these, if I don't do that, the earth's going to crack open and hell's going to rise up, right? Sometimes it's just more this perseveration, right? Perseveration, repetition, and more. If you've ever had someone who's perseverated on you, it's not just repeating. You know it's much more than that. Obsessive preoccupation with specific things, right? We got to leave by 9. We've got to leave by 9 if we're going to be there on time. We've got to leave by 9. Come on, don't you see what time it is? Or, don't worry, give me 5 more minutes, I'll be ready. I'll be ready. Don't worry, I'll be ready. It's this repetition and focus on things. So how do we see it in a clinical picture? Again, here's a great little example. You can read it on your own time, but I'm going to tell you that you are basically looking at 3 sentences. Okay? From about here to here is one thought loop. Okay? The anxious person is worrying that, oh my God, I'm not going to get there on time. It's not going to be right. They're going to think I'm stupid. They're going to realize how nervous I am standing in front of the room right now talking, and oh my God, is my fly down? And I don't even know what's going to happen next. An anxious person goes like that. I had to take a deep breath because that's what it's like. The anxious person gets into that kind of avalanche type thing. Well, not avalanche. It's like the snowball starting at the top, and it gets bigger and faster and gets more momentum. And I do have to check my fly just to make sure I wasn't blocking. Our example here is a great common example of someone who gets into that perseverative loop. Once you start worrying about one thing, you start worrying about everything else, and then you keep doing it. Okay? How do we treat anxiety? First and foremost, we're going to talk about an SSRI from those medications that we discussed for depression. One of the good ones for anxiety is Zoloft and Paxil are 2 of the ones that we see prescribed more in our clinic, and I see prescribed in the normal population for people with anxiety. Those antidepressants are great tools, but they take time, right? If someone comes in, they've been like, I've been anxious for 4 months, and you say, well, please take this antidepressant that's going to take 4 to 6 weeks to really get up to speed in your system. How likely is that person going to do it? Oftentimes people want one of these, but I'm not a prescriber, but I work with doctors who do, and we always caution on these medications, right? The benzos. The benzos are the pills that you take, and 20 minutes later, I feel good. Why is that problematic? You know, if I know that I can take a pill and I feel good in 20 minutes, don't you think I'm going to want to take that pill every time I don't feel good? Come on. They're easily abused, and they are addictive. So we want to use them with caution. We really want people to be aware. If you are taking Xanax and you come into my office and you say, yeah, I take 4 to 6 Xanax a day, well, that ain't right. Because what happens? You take a Xanax, it gets up into your system, and it's a short half-life. It's a medication that burns through your system real fast, which is why you feel good quick, but guess what? It wears off. And then what happens? Once the Xanax wears off, your anxiety goes bing again. So what do? You take another Xanax. So you've got this up and down pattern that can develop. And if we're talking about someone who has HD and who might have complications with thought processes, or who is slightly obsessive, 2 o'clock, I got to take my Xanax. 4 o'clock, I got to take my Xanax. 6 o'clock, no. So we want to be careful with medications like that.
What is too many and what?
Watch me get out of this one real easy. What is too many, and what was the second part? What's too many, and so what if they're addictive? Well, too many is going to be specific to each individual. If someone is early stage HD, I do not want to see them taking 4 to 6 Xanax a day, every day. If someone is late stage HD, this is not, I'm not a prescriber, but you talk to enough doctors and they're going to say, am I going to really tell the person who's late stage HD that they can't take the Xanax? This is going to be a questionable thing per doctor, okay? So it is very case specific. I don't mean to say that lightly either, but it is something. If you go to any of the long-term meetings, this is a big question. It's going to give a really cheap example too. Am I going to tell the person who's in, mid to late stage HD to stop smoking? I know that smoking is bad for you, but you really like it. It does bring you some joy. It gets you outside. The doctor in me says you should stop, but then I'm also a human being who's saying I'm empathizing with what you're going through. That, I just went off on a whole different tangent, and I apologize, because we are going to look for things that look like abusive patterns, and we will address them. But we will also look at each case specifically before making a judgment and making a recommendation that the patient may or may not choose to follow. Does that help? Did I tap dance around it enough? Thank you, sir.
What are you saying that there are other medications that for anxiety disorders
That don't have that?
That will be long-term helping with their anxiety,
Okay.
not just a quick fix
Right. Are there medications that have that long term? That is things like the SSRIs, but they take time to get into the system. They take a while to achieve a therapeutic dose, right?
But then more than likely they won't have those.
Right. You might have little ups and downs, right? We don't look at these things as sledgehammers, right? We don't want to snow a person in the early stages. We don't want to snow that individual because we want them to be able to function. We want people to have emotional responses to things because if someone comes home that yells at you, you have every right to get pissed off. But if it's like, oh, I'm on all these meds and I don't care that you're yelling at me, well, that's a problem. There might come a time where we do want someone in that state. But I would encourage people, and this is again, look, we're talking early stages. We want people to be as functional as possible. So if you are getting over-medicated, that's not always a good thing. So hopefully what they do is bring a person a little bit more under control so the ups aren't as high and the downs aren't as low. It's more fair to middling like that. Okay? There are some heavier hitters in case you just can't control it. And this is oftentimes seen in people who might just have anxiety. You got the gene for HD, you probably got enough stuff going on in you too that might give you anxiety as well. It can be there even though it's not associated to HD. People with HD can have bipolar, right? People with HD can have things that look like schizophrenia. Do we say that it's schizophrenia? No, we usually say no, it's the HD just because we know it's there. But these things can be happening, right? So if it is really, really bad, we will snow a person. I use that term, I don't mean to joke it. We heavily medicate people, and some of these neuroleptics or the antipsychotics hit a lot harder than these other medications. We don't want to see those used as a first line. We want to try everything in kind of the least difficult to the most difficult, right? These have the least amount of side effects. These are the most easily tolerated, and these have some of the best benefit. These people can use and get good benefit from it. If you manage them right, they're great drugs, right? I don't want to say that you shouldn't go on these, but you really need to be aware of how you're using them. These we're going to only pull out if everything else isn't working. How can you deal with anxiety besides taking a pill? Talk about it. Talk to someone. Cognitive behavioral therapy has some great protocols specific for dealing with anxiety disorders. These are standardized techniques that have been tested over and over and over and over and over in the quote-unquote normal population. Do we have a lot of research on CBT in HD? No. But try it. These are great techniques. They are great ideas. They have some very specific hands-on things that people can do. A lot of these things that follow right here are all derived from CBT treatments for anxiety. What do we want to do? We want to identify triggers. If I know that every time the monthly bills come around, I get really anxious, that's a trigger. So we can work with interventions around that trigger. If I get really anxious every time I know that the in-laws are coming over, that's a trigger. How can we work with that? What can we do? You want to identify the thoughts that come up with that. The bills are due on the 15th. Oh my God, I'm not going to get paid on time, and if I don't pay them, we're going to lose the house. And identify those thoughts. Why? Because we can work with those thoughts. We can challenge those thoughts. If I don't pay the bill on the 15th, are they going to repossess the house? Well, I've made every payment up until now. Okay. We just want to bring the anxiety level down here. I'm not talking about the actual payment on the house. We want to address the person's level of anxiety because that's going to allow for them to do more functional things. We want to do simple thought challenges. We also want to do simple things like talk positively to ourselves, right? The anxious person is, I can't do it. There's no way I can do it. I am going to lose it in front of that room. I can't do the speech. I can't tell you how long I was sitting in the back going, you can talk to these people. You can do it. You know what you're talking about. Now that I said that out loud, I'm getting a little more anxious about it, but I'm talking to myself in my head saying, it will be okay. You can do this. It sounds so simplistic, but sometimes it's those really simple things that help. Lastly, practice relaxation training techniques. I think there was a guided meditation that happened earlier today that I want to get my hands on because things like that can be really useful. Relaxation training can be as simple as this. If I'm getting into that loop and I'm starting to freak out, take a breath. What am I doing? I'm focusing on breathing instead of those thoughts that are rushing through my head. If I'm really stressed out, I'm going to take 10 breaths, and I'm going to pay attention to every single one. Practice these things. There's some great protocols out there. You can find them really easy. You go to Barnes & Noble and Borders, and you go to Self-Help, and there's like a book that thick of relaxation techniques. Sometimes it's just as simple as breathing. Sometimes it's imagining you're a leaf floating down a river and the sun's out. And those are awesome. That takes too much time. I take a breath. Apathy. I'm not taking enough breaths because I just look at like, oh, we're going to run out of time. Apathy. Apathy is that thing that is very difficult. This isn't a psychological diagnosis. This is something that can be a part of depression, but it's something that's very common in HD. How do we see it in early stages? Well, it's this thing where it seems like I'm not as invested in the things that I used to be. Hey, you want to go to the game tonight? Meh. Did you get those chores done? Oh, yeah, I'm done. No, I'm into it. Hey, can you turn the TV off? You've been watching for like 4 hours. Right? You've seen apathy. It seems like this indifference, or this is like not being engaged. We talk about it as being hard to get started. Right? The person who has apathy has a hard time starting a thought, starting an action, starting an activity, starting a chore, starting whatever. Who's the early stage person who's having a hard time getting out of bed in the morning? You've been doing that for an hour. You going to go? Okay. Are we talking about apathy, or are we talking about where it gets a little more complicated? It's hard to differentiate it from depression sometimes, because remember, our depressed person doesn't want to get out of bed either. I'm just going to sleep for another half an hour. A person who has apathy is not necessarily depressed. I just don't feel like going. Not that I'm in a bad mood. It's not that I'm sad. Why? I don't want to go. I don't think it's important. However, they do often coexist. So just be aware of that. Here's our apathy example is an IT dude, right? He's a baseball. No, he's not a baseball fan. I've had this thrown at me multiple times. I'm not a baseball fan, so I say, oh, you're a fan of baseball. I am not a baseball fan. I'm a Dodgers fan. Okay. I don't get the difference, but I'll respect that. Here's our apathetic guy. He's just having a hard time getting started. And it's different. Why is this a problem? Because note that his brother's getting pissed off. This thing that is starting to present in our HD patient is affecting his relationships. I don't think I've hit on that enough with our other examples, but why are these psychiatric things important? Because it changes things. It changes the way you interact with work. It changes the way you interact with family and friends. It changes the way you interact with the environment. It changes the way the person with HD gets involved with the world. So there's things that you can do about it, okay? Dave, just push him out the door. Here we go. How can you treat apathy? Well, you got to be careful here, because if a person is not depressed, throwing in antidepressants isn't always the best thing. Well, I've been taking Zoloft for 4 months now, and I'm still not feeling any different. If they do have comorbid apathy and depression, it's a great thing. Sometimes, like I mentioned way back when, drugs like Effexor tend to have this side effect, which causes people to get a little bit revved up. If a person's apathetic, if you prescribe a medication like Effexor and they take it in the morning, and about a half an hour after taking a pill, they might have a little bit of a jolt, and it gets them up and it gets them going. It doesn't always work, because that side effect isn't guaranteed to happen, but it will sometimes be used in cases like this. There are other things that we can have prescribed, like these psychostimulants. Ritalin, Strattera for the person who's having a hard time concentrating, Provigil, legalized speed. Right? These things get people going. That was a really horrible thing to say. Provigil can be abused because it does cause people to get that burst. But for a person who can't get going, Provigil can be a good thing. How do you treat it behaviorally? This has a lot to do with the other people. If you have someone in your life who has apathy, they're not lazy. Do not interpret apathy as laziness. Why didn't you take the trash out? Just, you're so lazy. No. If the person has apathy, it's not laziness. Could they be lazy? Absolutely. Could an apathetic person be lazy? Absolutely, and that makes it that much harder for you. don't immediately go in your mind as the person who's dealing with an HD person who has apathy that they're lazy, because it's going to change the way that you think about it, and now you're going to get into a whole more complicated mess. So don't interpret it as laziness. Educate people. Come to things like this, get notes, and then go home and say, here's what apathy is, right? Friends, family members who couldn't go to the convention, this is what apathy is. Dad, not lazy. Dad, apathetic. It's different. We might change the way we think about Dad and therefore change the way we act with Dad, which might change the way that Dad acts with us, right? If I think Dad's lazy and I'm getting on his case, again, Dad might be planting those heels and going, oh, all right, now I'm really not going to do that. Okay? It can be really frustrating. You want to be supportive to people who are dealing with someone who has apathy because it is frustrating. This isn't the person that I married. Right? Man, you used to want to go out every Friday night. Now all you want to do is sit there. You don't even want to watch a show together. And if we do watch the same show, you don't want to talk about it. It can be very frustrating to the person dealing with it. Encourage participation. This kind of goes back to the depression thing. Encourage it, but respect no. If you push too hard, it's going to break. Kind of a simple analogy there. And again, calendars, schedules, routines. Oh my. Irritability and anger. Again, it's not a diagnostic category, but boy, do we see it a lot. And are there things we can do about it? Absolutely. I'm not going to go through all of this because I think you all know what irritability and anger looks like, but in an early stage person, it can sometimes be more subtle. It's not you coming and getting in my face and screaming. It's just, man, you've been yelling a lot about things. It's easier when it's really super obvious, right? Dad, who is in the mid to late stages of HD, is rushing around the house with a baseball bat, hitting things all the time. Ooh, anger and irritability, got it. 32-year-old man who loses his temper once in a while, who gets really frustrated at work and yells the whole drive home. And then when he gets home, he's so wound up that he's got to go chill out for a little bit while. This is a little bit more subtle, right? Because that could just be anyone driving in LA. Or, sad, that's me too, but it gets harder to suss these things out, which is really why you want someone who's like me, your medical doctors, et cetera, involved, because you want people who have a little bit more of an idea who can try to take a fine-tooth comb to these things and really see. Oftentimes it's exaggerated. Look, you might have a real good reason to be pissed off. Yep, I just poured a hot cup of coffee in your lap. Sorry. If you're angry about that, that's okay, but it might be exaggerated due to the HD, right? That executive dysfunction that we talk about, or the caudate nucleus gate that doesn't close, we might be seeing a bigger response than what is quote-unquote normal because of the HD. Does anybody not know what irritability and anger look like? Those look, there's many different ways to see that. Read about Debbie. She's pissed off. Why did I include this example? Because she's not talking, she's yelling at her kid, right? This is when irritability and anger can become problematic. It affects the whole family. Her daughter's in the room, mom's outside pounding on my door and screaming. It can be really scary and can affect the whole family dynamic. How can we treat it? Talk to your doctor about medications, like an antidepressant, because very often anger can be a manifestation of depression. Depression isn't always crying, checking out. Sometimes depression looks a lot like anger. Talk to your doctor because they can help suss that out and apply any of those medications we talked about earlier. Mood stabilizers. We tend to see these used more as the person progresses in HD. Mood stabilizers kind of help to really bring a person to a baseline even more, right? I would say before, the antidepressant kind of helps minimize these things. The mood stabilizer really helps to minimize these things. But we want to use those thoughtfully. If the person is really out of control, we'll try things like antipsychotics. If a person has uncontrollable rage, we'll try some of these things. And these are some of the big ones that you hear. What's interesting is you also hear about all of these when we're talking about controlling movement in HD. Right? Why? Because the side effects of those meds cause people to slow down and become a little bit stiffer in movement. So if a person's got a lot of chorea, we will use these medications to try to control that. But we see it being more problematic in early stages, because what if you don't have a lot of movement? And now we're prescribing a medication that slows you down and kind of clouds your thinking, which you're in early stages and you're just beginning to have cognitive problems, and now we throw a med that just makes it even worse. That's another thing about the benzos. Sorry, I totally forgot that. You take Xanax, guess what? Makes you a little muddled. And if you have cognitive issues too, that's just going to exacerbate them. What can you do? Talk about it. Come on, by now you should all be in therapy because it's the be-all, end-all. There are some great strategies for anger management. There are great techniques and tools. There are manuals. There are protocols, things that you can follow that are really great and can be very useful. Identify the triggers to the anger and irritability and try to remove them if possible. Well, if you're pissed at your wife, how can you remove that? You could. You're right. I mean, that is an option. Someone said divorce for all of you online. Hopefully it's not that severe. Like, you know, if it is this particular day where all these things come in at work, maybe I need to address that with my boss. You know, can we change the way this thing happens? There's ways to address it behaviorally. You can modify triggers. Again, take a breath. If you are a person who tends to get pissed off, if you feel your temper go from here to here really quick, but you're aware of it, hold on. I'm just going to keep doing this for a while. People might, you know, you might worry the social anxiety thing again. People think I'm a freak because I'm over here taking deep breaths in the corner. But you know what? They're so much happier that I'm doing that instead of screaming in their face. Right? Take a breath or 5. That's supposed to be funny, but take as many as you need. Change expectations in the way you interact in relationships. Change the way you do that. It's something that's going to happen as you progress with HD that you're going to want to do actively. Start at an early stages. Start practicing all these things early on. Why? The more we practice anything, the better we get at it. Practice adaptive things starting early on. Why? The hope is that they last long, that you get better at them and you get a better effect from it. It's not a guarantee, but the more you practice something, the better you get at it. We all know that with our bad habits, right? The person who smokes a pack a day and then, no, I'm still good at smoking a pack a day. Why don't I smoke a pack and a half a day? In a couple of years, why not 2 packs a day? Look how good I'm getting at this. Do something beneficial. You could have the same result. Learn how to compromise. When you figure out how to do that, let me know. Most importantly, know when to leave a situation or seek help. If you are dealing with anger or irritability, know when to get the heck out. Whether it's leaving the room, whether it's leaving the house, whether it's calling the police, know that there may come a time where you have to do this, and don't hesitate to do it. Because first and foremost, we're worried about your safety. Hey, we're at the end. So what I hope you got today in only the few minutes that I've gone over, and I will entertain questions because it's my fault we went over, but you can all leave if you want. What are some of the early psychiatric presentations? It tends to be those basic ones that we see. Depression, anxiety, along with those apathy, anger, and irritability. There's weirder things that can happen. We don't see them as often. If you want to talk about those, I'm more than happy to discuss it later. What are the signs and symptoms? Those are those things that I listed. Like, what does anxiety look like? What does depression look like? You've got a nice list on there. Again, please go home and read this stuff. Share this stuff. The examples, they're for you to read. Hopefully you see something in there, HD or not. You can probably read it and go, I know that person, or oh my God, that's me. Medications, talk to your medical doctor, everybody. Medications should not be done just because they're in the house. Medications should be done because you've talked to someone about them, they've prescribed them, and they're going to watch you use them so that nothing bad happens. And lastly, I should have just written, talk about it. Come on, go to therapy. Awesome. Coping strategies are active techniques that you can use that you can achieve a lot of benefit from. You can do it on your own. You absolutely can, but man, it's so much easier if you've got someone you can work with. There are people in the community that do these things for a living and have been trained to do it. Now you're probably thinking, well, they don't know about HD. Great, there's not a lot of us out there who are clinical psychologists who specialize in HD. I'm in Los Angeles, which is a great big city. I'm the clinical psychologist who works with HD specifically. I've got people who are like, oh yeah, I worked with one patient. Fired them. helping me a lot, other psychologists. That's awesome. People might not know it, but they can learn it. If a therapist connects with you and you feel good with that person, we can teach them about HD. You as an HD advocate and ambassador can teach them about HD. Or you can say, go to this website, www.hdsa.org. Not hard to remember. Tell someone to go look it up. If they're a good therapist, they're going to meet you the following week and go, hey, I was reading some of that stuff on the website the other day. And in fact, I actually went to the library and I read a little bit more about it. You can find people who are good at working with other people on issues like depression, anxiety, anger, apathy. They might not know HD, but they can learn it. Find someone who was what I call a good fit. You want to be in a room with someone that you feel good about. You feel like, okay, I can talk to this person. That's most important. We can talk to them. We, providers like myself, consult and educate. You, HD ambassadors and advocates, can provide literature or websites. People can learn it. The more people we can teach, the more people that are going to be out there for the next person who comes through the door going, I need to deal with this. This shouldn't answer all of your questions. I'm not that good, and even though I might believe it, I know it's not true. Hopefully it gives you something to start a conversation with. If you live in a place where you've got a center of excellence, awesome. If you live in a place that doesn't have a center of excellence, do you have a doctor that you like? We can share information and resources and are more than happy to do it. Okay? If you can get to someone who specializes in HD, fantastic. If you can get to someone who's a good doctor, fantastic. We'll teach them about HD. Take this as motivation to look for tools. Speaking of tools, if you want to get in touch with me, you can gladly send me an email, and I will gladly respond saying, find someone in your area, but I'm sure as heck willing to help. Okay? My parents are in the room. That's why I just had to correct myself from swearing, which was what I was about to do. Don't hesitate to ask questions for those of us who work in this community, because we want people to get the best care possible. And if that means us educating other people, we're willing to do it. Okay? Thank you all very much for your time. I did not mean to say that before I said, are there any questions? Yes, ma'am. Absolutely. The question was, do we have handouts? That one I can say, yes, indeed. Please come on up when you're ready to go, and we'll give you as many as you want. Anybody else? Yes, sir.
Do you work with people who have addictions to street drugs? And have you found that typical treatment works for a person who has HD and addiction to the drugs?
Okay, this was a good complicated one. Do I or we work with people who have addictions to street drugs? And does the treatment work the same as people who have HD dealing with addictions to street drugs? It's more complicated. It is absolutely more complicated because of these changes in the brain, right? The cognitive changes, the behavioral changes, the psychiatric changes make addiction a different thing. Can people do it? Absolutely. And again, this is anecdotal. This is only from people that I've met in clinic or worked with. I have seen people go through rehab programs. I have seen people do it on their own. I have seen people succeed, and I've seen people fail miserably. It is more complicated. But I would recommend going the traditional route first. Why? Because addiction is something special in itself, right? Add HD to that, it's more complicated. Addiction specialists have a different level of training, and they tend to be much better about this intense work that you need to do. We'll add a layer of education in HD into that treatment. Does that answer your question in a good psychological way?
Is it more common?
Is it more common? That is a really good question that I don't know the answer to. And that's something that for early and pre-symptomatic individuals, that's something we'll probably see come with the literature that will come from the PREDICT study. Why? Because in that cohort of people, right, in the people who are doing PREDICT, who are early or pre or early stage, we talk a lot about addiction. We talk a lot about drug abuse and use. So I don't know any PREDICT people in the room that want to say anything about that. I don't know if there's been any papers written on it, but we can find that out. That's a good question. Sorry, I don't have an easy, immediate answer. Yes, ma'am.
What's the difference in the psychiatric issues between juvenile HD and adult onset?
Okay. What is the difference between the psychiatric issues between juvenile HD and adult onset? Generally, the juvenile HD psychiatric features are a little bit more intense, right? A lot more acting out, a lot more, it's going to look more like the child who has oppositional defiant disorder, right? It's much more aggressive and acting out. With adults, it's usually a little bit more insidious onset too, right? And that's just because those two, the juvenile classification HD looks very different than the adult classification. So it's a little bit more intense, for lack of a better way to summarize it. Dr. Jane Paulson is going to be talking about JHD tomorrow, I believe. Those are hers. Ask her the exact same question. Yes, ma'am.
You made a statement about calling law enforcement. I am in law enforcement, and I know there's a lot of lack of education on HD, and like you've been recently challenged for the tax court on that. Is there a program in LA for jailers, law enforcement, that, I mean, I don't want to have to reinvent the wheel. Is there something already in place?
The question was about the statement made about calling law enforcement and how law enforcement, as a law enforcement agent yourself, you know that there's not a lot of education out there. Is there anything in place, particularly in LA? No. However, let's talk, because I would want to have you talk to some of the HDSA folks. Manelli, do you know, is there still a law enforcement working group? I think there had been something proposed a while ago. Okay.
We're working on it.
Okay. What's your name?
Lynn Ross.
Lynn, and you are Diana? Diana? Lynn, Diana, please talk. I think it's super important. It's something that we would love to be able to have to say, educate police workers. I can't tell you how many times we hear this in clinic. Well, yeah, he had me thrown up against the wall, and he was shaking me and hitting my head against the wall. I managed to get away. I called the cops. The cops came, talked him in the driveway, let him out of the car. Oh, boy. Come on. Or just even more simplistically, someone with HD gets stopped while they're driving home from work. You're drunk. No, I'm not. You're drunk. No, I'm not. Let's do a field sobriety test. You're drunk. There's a need for it, and there's a need for standardization. So please do have that conversation. And if you haven't, talk to our national chapter about that, please.
There was actually a workshop done earlier today, and you may be able to find the presentation online next week. And it was one that said explaining HD to the community, and we actually had.
Oh.
They're doing it tomorrow, yeah.
So tomorrow, go to explaining HD to the community, introduce yourself to the speaker, and say, I want to do something about this, please. Thank you. Yes, question in the back. Comment.
I have on my doctor printed out the name, so I have
Glad to hear that. Yeah, no, there is, what was just shared, and I appreciate that, is there is some printed material that says, I have HD, and this is what HD is. It looks like a little business card, and it's provided by HDSA. Oh, even better. You have something from your specific doctor. Okay. There are these little business cards that you can get, that you can carry in your wallet, that is a fantastic tool. Or if you've got a doctor who's willing to write a larger statement for you, that's even better. Keep it with you in your wallet, in your purse, in the glove box, whatever, right? There are tools that you can have. Hopefully the more people are exposed to those things. You know, we get it. I just think of someone who went into a liquor store. She was going to a party and she wanted to buy a bottle of wine, and they would not sell her a bottle of wine because they said she was already drunk. She didn't have that card. She tried to argue. The store owner was like hollering at her, made her feel really, really horrible. These things happen. It's not just getting pulled over by the cops. It happens in places like that. Man, I was going to a birthday party and all I wanted to do was bring a bottle of wine. It's about educating the community, and I think that thing that the presentation tomorrow is another good example. Things that we should talk about. Yes, ma'am. Is there a larger population of alcoholism in HD? Another one that I don't have a good answer for. I don't have an exact answer for that. Is there a higher rate of use and abuse? Anecdotally, if we look back like a generation or two in HD, those were the, well, we didn't know mom is HD, we just thought she was drunk, right? Oftentimes people who are dealing with something, whether they're aware of it or not, are trying to self-medicate. Man, I'm stressed out all the time, so I'm going to have a couple of drinks. Am I stressed out because I'm anxious? Am I stressed out because I'm HD? Are people self-medicating? It happens. I don't know if it happens more. We might assume that it does, but we can look that one up. Sorry, I don't have a specific answer for you. Yes, ma'am. Yes, in the brown blazer. Thank you.
My question has to do with the intersection between HD and bipolar disease. I have a couple of relatives who are diagnosed manic depressive, but it's possible that they also have.
Yeah, you asked a really good question. Yep. The question was, what about the intersection between HD and bipolar disorder? The easiest way to answer this one is you have family members who appear bipolar, who kind of have these big ups and downs.